Bismillah ar-Rahman ar-Rahim. In this presentation we are going to discuss the basics of cochlear implant, its indications, expectations, and how the surgery is generally done. The history of cochlear implants with the first implanted candidate was in 1961, headed by the team of House Ear Institute in Los Angeles, California. And this device is arguably the most successful device to replace sensory deprivation in the human history. In Ain Shams University cochlear implant team started the center in 1994 with the clear objective of having safe implantation in properly selected candidates and with realistic good expectations. The cochlear implant is a device which uses electricity to stimulate the spiral ganglion cells or the remnant functioning ganglion cells of the auditory nerve, bypassing the damaged hearing apparatus in order to restore sensorineural hearing impression. Teamwork is needed to make this device effective in perceiving this sensation of sound. The inner ear is composed of membranous part and the bony part, and the movement of the fluid deflecting the organ of corti and tectorial membrane is responsible for the perception of hearing. So it is acoustic stimulation using the sound waves to stimulate the inner ear and transferring impulses to the auditory nerve. On the contrary, the cochlear implant is an implant or a device which conveys electrical stimulation to the ganglionic cell and then transferring it to the hearing center. The important points that the inner ear and the cochlea got important structures in functioning as a hearing device or a hearing organ. And these main options is the special arrangement of the cochlear duct, the presence of the modulus, and the presence of the spiral ganglionic cells, which is a target for stimulation after cochlear implantation. So the cochlea got also a tonotopic principle, meaning that the high-pitched sounds are perceived at the base of the cochlea, while low-frequency ones are perceived around the apex of the cochlear term. This is important in patients with preserved low-frequency function while having severe to profound hearing loss affecting high frequency. In this hearing preservation mechanism, there is a device called hybrid cochlear implant, which used acoustic and electrical stimulation in selected patients. So the electrode is placed mainly in the scala tympani near the ganglionic cells, and the modulus are very important structure in detecting and anticipating the outcome of the surgery. So again, the cochlear implant is not a hearing aid, doesn't cause louder sound. Instead, it converts acoustic sound into electrical signals by passing the damaged part of the auditory system. There are many devices, but the main components are external and internal parts. The external part are the microphone, sound processor, and the transmitter. And the internal device are composed of receiver, stimulator, and electrode. According to the manufacturer, there are external parts may be either wireless, like this one, or wired with a wire connecting the microphone and speech processor to the transmitter. The internal part is composed of receiver, stimulator, and electrodes. The electrodes are different lenses in order to suit different surgical situations, and there are double arrays to be used in specific cases of cochlear ossification. For example, the Cochlear company provides different types of electrodes, either perimodular or precoiled, and straight ones. Also, the other companies provide different portfolio, and some of them provide the double array to be selected in specific cases. Also, the hybrid one is useful in selected patients with preserved low frequency function. According to the length of the electrode, the shape of the post-operative and the depth of insertion varies. If the electrode is long, it takes more than 360 degrees. If it is short, like in the hybrid one, it doesn't complete a circle. And this is very important to select the proper length of the electrode which suits the anatomy of the cochlea. There are some modification of the cochlear electrodes as used. Either we want to make it closer to the modular hugging electrodes with advantages and disadvantages, or laterally placed electrodes, or midi-scalar ones which has specific indications to avoid extracochlear stimulation and specifically advisable in cases of advanced cochlear otosclerosis. The stimulating part of the electrode is either a localized one facing the modulus and the ganglion cells, or a complete circle causing more widespread stimulation, and of course it uses higher power to be functioning. So the selection also depends on whether you need more field stimulation or localized stimulation. The predictors of success in adult patients depends on the onset of deafness, the duration of deafness, the mode of communication, the commitment, and the motivation. And the pediatric age group, the age of implantation is very important before the age of 5 years in order not to lose the plasticity of the brain, which affects the development of the language system. If it is not stimulated before that, it will not going to be developmental. The mode of habilitation or rehabilitation is very important, and above all, the family support is essential in these cases. In general, the indication, the patient should be suffering from bilateral, severe to profound sensory hearing loss, either prelingually or postlingually, not benefiting from hearing aid. This is very important. The children consideration is very important regarding the age of implantation and whether to use sequential or simultaneous bilateral implantation in specific situations. In most of the centers now, the minimum age of implantation is about 12 months, but the age has to be modified, especially in cases of meningitis with the fear of having ossification of the cochlea. The other prerequisite for the cochlear implant is to have an intact functioning cochlear nerve and a reliability to follow up with audiology and otolaryngology team for life, especially in pediatric patients. And the prerequisite of having general health fit for general anesthesia and surgical procedure. There are special situations for in cochlear implant in children under 12 months because there is a problem in the audiometric and speech perception evaluation in this age, and of course the tolerance of the surgical risk of the procedure. Another special situation, the issue of bilaterality, to have bilateral cochlear implant, either simultaneous or sequential cochlear implant. And if you have a patient with impending cochlear ossification, this is another consideration which affects the decision markedly. Single-sided deafness are recommended in some centers to be implanted. Auditory neuropathy cases with guarded prognostic expectations and very tough evaluation procedure is another critical issue. The use of hybrid or the electroacoustic stimulation in patients with preserved low frequency loss is another special situation. The bilateral cochlear implantations It has certain function and certain advantage over unilateral one, but we have to remember that there is a concern about the simultaneous implantation as it entails longer OR time, but the sequential implantation, it is believed that it is best for children under the age of 8. Unless the child is fitted with a hearing aid on the other side, because after the age of 8, it is difficult for the brain to perceive and integrate the impulses from both sides. So definitely having 2 implants got a definite advantage, like better localization of sound, better hearing in background noise, summation of the binaural stimulation, and decreasing the impact of head shadow effect. All these strong stimulation of the brain center overcome the problem of the brain spasticity and plasticity, as it is known that either to use it or lose it. This is valid for other senses and of course for the hearing and language development. The patient listens with less effort, and he can appreciate high quality sound perception, like enjoying the music. The problem of the bilateral implantation, that you are destroying the residual hearing on both sides, and the patient will not be able to benefit from the future improvement in the hearing technology, and the surgical risk is higher. The hybrid C cochlear implant, as we mentioned, use a classical hearing aid with a shorter electrode, and at the same time using an acoustic stimulator which looks like an in the canal hearing aid. Contraindication of cochlear implant: if you have a serviceable hearing level which can be magnified, if the patient has cochlear aplesia or absence of cochlear nerve, other congenital anomalies of the inner ear may be amenable to implantation, like the Mondini deformity, but the discussion and the complications has to be discussed with the family. If the patient, of course, cannot tolerate general anesthesia, is not a candidate for cochlear implant. The surgery, before the surgery, you have to review the vaccination schedule of the patient. You have to do CT and MRI imaging. You have to check the equipment, and it is advisable to be done at a highly equipped center with backup of the microscope and the drill system. Some areas necessitate the presence of facial nerve monitor to license a center for cochlear implantation. The second decision, which is very important, to decide which site to implant and to select the device for the patient. Ear examination for infection and anomalies are done. Audiological assessment, trial of a hearing aid should be assessed, and CT and MRI funding, psychological evaluation of the patient and the child and the family is very important. General physical examination, sometimes with genetic background, genetic counseling is needed. The imaging, we do CT scan to detect abnormalities in the inner ear structure and the internal canal. If you detect any anomalies of the cochlear formation, you may request MRI to confirm the pathology. And the CT scan role is to be sure that the patency of the basal turn of the cochlea is intact with normal round window area, and the parts of the cochlea are well formed. Another important value of CT scan is the surgical planning. You have to check the pneumatization of the mastoid system and the trajectory to the posterior tympanotomy approach, and to detect any anomalies which would put the facial nerve at higher risk, like dehiscence or prolapsed facial nerve. Other anomalies which are important to be detected by CT and MRI is the enlarged vestibular aqueduct, which is confirmed by MRI showing enlarged vestibular aqueduct and sac. Special situations like advanced cochlear otosclerosis is important to be identified to select the proper electrode and to avoid surgical encounters. The MRI, again, the main role is to be sure that the cochlear nerve is well formed and the cochlear turns are also well formed with the modulus and the bony partitions intact. The details of the inner ear and the cochlear structure is important to identify the turns and the cochlear modulus and the base of the cochlea. The sagittal cut is very important and has to be done for all cases to be sure that the cochlear nerve is formed and of the same size like the facial nerve. Which ear to implant is a controversial issue. Some people say that it may not matter to implant the worse or better ear, but in general, the ear with the shortest duration and with worse hearing, and it goes with the handedness of the patient, is to be selected. If there are no audiological difference between the two ears, then choose the better surgical one. The better surgical one is the one with ideal mastoid pneumatization to be drilled, and the side with the least ossification or fibrous or obliteration of the basal turn of the cochlea, and the side with the normal anatomy. The surgery is done under general anesthesia without long-acting muscle relaxant. Usually it takes about 1.5 hours to 3 hours, usually also as a day care or 2 days hospital stay. The activation of the device or the application of the external part is done after about 4 weeks. The steps, it goes in this stereotyped pattern: incision, mastoidectomy, seat for receiver stimulator, which is sometimes modified by the tight subperiosteal pocket, posterior tympanotomy, round window exposure and or cochleostomy, insertion of the electrode, fixation, testing and imaging, and at the end layered closure of the incision. The classical incision is either an extended post-auricular one or an soft S-shaped one, or the extended endooral with the application of the minimally invasive technique. A shorter straight incision is done. The main steps include cortical mastoidectomy without too much suturization. The identification of the round window and short process of the incus are essential. Opening of the posterior tympanotomy, preserving the chorda tympani and the facial nerve is important. Taking care of the abnormalities of the landmarks like the dehiscence of the facial nerve, which usually affect the transverse part. The incision and the procedure is done after elevation of the flap post-auricularly according to the preference of the surgeon. The exposure and doing cortical mastoidectomy, thinning of the posterior metal wall is important. Keeping overhang of the cavity is important to keep the electrode in place. Doing posterior tympanotomy after thinning of the posterior external canal wall, identification of the round window and round window membrane is very important. Taking care not to injure the facial nerve or the other structure in the area. Some modifications of the surgical techniques are not the issue of my topic today, but it relates mainly to the fixation technique, how to fix the receiver stimulator. The electrode insertion options is either through the round window, extended round window, or through a cochleostomy. And the soft surgery approach entails shorter incision with no suction of the perilymph, with prevention of blood to get entrance into the cochlea, application of local steroid or Helon during insertion, slow insertion speeds, and we have to stop when there is resistance in advancing the electrode. After insertion of the electrode, the device testing is important with telemetry and ECAP, combined action potential, and the plain X-ray to identify the location and the configuration of the implant. This is very important to monitor the post-operative situation of the implant and to correlate with the telemetry findings. Definitely the cochlear implant got advantages, like it changes the patient from a handicapped one to a person who have hearing communication in a normal way, and to understand the speech without lip reading, and it helps with speech. Sometimes the patient is able to detect music and to enjoy sounds like speaking over the phone or enjoying music, and it allows for communication directly without the help of other methods like the language, the sign language, or the lip reading. But there are certain disadvantages, like the surgical risk and the higher possibility of having meningitis, and the implant could be negatively impact the activity of the patient, who will not be able to share in combat sports. And there are possible side effects like the risk and the complications of damaging residual hearing, affection of the facial nerve either permanently or temporary, meningitis or CSF leak very rarely, and the major issue of having device problem or unpredictable response, which I think this is one of the major problems in discussion with the patient, is to predict the response to the cochlear implant. The skin infection is serious, and it ranges from simple ones to major ones with skin necrosis and protrusion and extrusion of the device, especially if it is associated with biofilm and infection. So also the patient will be prohibited from certain activities, and there is definite limitation of medical testing in the future as the device contains a magnet, but now they are trying to modify the magnet to allow for some MRI imaging, either after removal of the magnet or with the magnet in place. So the effectiveness of the cochlear implant depends on the structure of the cochlea, the number of stimulable nerve cells and ganglion cells, which I said we cannot judge it before surgery, and implantation variables, which includes the type of electrode and depth of insertion, the signal processing technique, the learnability and the communicativeness and the intelligence of the patients are major factors. The length of the time the person has used the implant is also important. The quality and dedication of the rehabilitation team and the family are very important factors. So in summary, the cochlear implant allows speech development, speech restoration in postlingual deaf, restoration of hearing, which has numerous implications as a spectrum from either a safety or a warning signaling device till the spectrum of perceiving music. And the patient is expected to be integrated into regular classroom settings, and the potential for increased earning potentials is higher than before implantation. We have to remember that it will take time to cochlear implant to be effective. There will be no success without the follow-up and rehabilitation services, and having a cochlear implant does not guarantee the ability to speak. الحمد لله الذي رزقنا نعمة السمع والباقي الحواس، وفوق كل ذي علم عليم، الذي رزقنا هذه المعلومات وعلمنا ما لم نعلم. شكرا جزيلا.